It's my privilege to welcome my batchmate, Dr. Yasar Safar, for his talk on approach to lid swellings. He is a consultant oculoplastic surgeon at Agarwala Hospital, Trivandrum.
Good evening. Thanks to KSOS and Dr. Soumya for this opportunity. Now I will be dealing with the pediatric eyelid swellings, how to proceed. Like when you get a pediatric eyelid swelling, what are the things that you have to look for? So we have gone through multiple sessions, like the simple one to the aggressive ones and to the rare and through the rare ones. So how to manage a case when you get a case. So as in Dr. Abarna has mentioned, you can see chalazions, you can see granulomas, you can see dermoids, you can see allergic reactions, you can see simple small neosis, or you can see a capillary hemangioma. Sometimes you can see allergic conjunctivitis like VKC kind of picture, or even a parasite or a tick. And sometimes they may present acutely with red swollen eye like this, with orbital cellitis, dacryocystitis, etc. And sometimes you can have some hidden threats like mostly parasitic infestations, AV malformations on your thyroid eye diseases, or like round cell tumors, which are pretty common in pediatric age group. So mostly when we come to the cause, it can be mostly allergy, especially if the swelling is not tense, and if the kid or the parent gives a history of any allergen exposure, or sometimes can be an insect bite, or sometimes maybe medicine, or sometimes maybe something some intake. But mostly the allergic edema will be bilateral, and the other next cause could be inflammation. The allergy causes will be usually acute in onset, and the child won't be that toxic. The coming to the inflammatory markers, there will be some kind of inflammatory signs. There will be erythema in duration, and in case of infections, the presentation is mostly in pediatric age group. It's acute to subacute, and the vascular lesions mostly will be from birth, and or there will be some signs at birth, and which as the child grows, the presentation will become more evident. Neoplastic cases, as discussed earlier, is not uncommon in pediatric age groups. So how to proceed it? So as in the a history of present illness, we have to go through where is the location of the tumor, or where is the swelling located, and the characteristics or the quality of the tumor. We have to describe any adjacent lesions or any surrounding lesions, any hair fall, loss of hair follicles, any induration, erythema, such kind of things. This timing, onset, duration, and timing is also important. When the lesion has begun, whether it was there from the birth, or it has begun 2 weeks or 3 weeks from the birth, or has it gone from at an acute onset or something like that. And you should look into any aggravating or relieving factors, or look into the other symptoms like fever, malaise, nausea, such kind of things also. So basically you should look into the character of the kid also, or when they present to us, as we complete history, you should look into the general examination also. Look if the child is toxic, if the child is febrile, if the child is pale, and look for the chest and abdomen also, because pediatric neuroendocrine tumors or round cell tumors are not uncommon. And torsilate examination is becoming uncommon in ophthalmic practice, but make sure that you do a torsilate examination in pediatric eye group, because many things that you can miss in a slit lamp examination could be found in torsilate examination. And make sure that you do an inverted eyelid examination in all cases in pediatric lid tumors, and use a bud or a retractor to make sure that you see the tarsal plate, and look for look for any postal variation when the kid presents you, or like do a Valsalva manner if needed, and go for the slit lamp examination after you finishing these basic examination. And imaging is needed whenever you find that the swelling is extending beyond the fornices, or if it's extending beyond the tarsus, or if it's extending into the orbital diseases. So why you want to look into the general examination? See the first picture is of a kid who presented with a subconjunctival hemorrhage, and the parents were not giving any history of any trauma. 2 weeks later, the initial surgeon, the initial ophthalmologist thought it's to be some traumatic. The kid is not giving a proper history. But 2 weeks later, the kid presented with hypertrophy. And on imaging, there was a mass and eventually turned out to be neuroblastoma. And and that's the importance of a kid presenting with such kind of subconjunctival hemorrhage in ECMS. Also make sure that you get a proper history, make sure that you see the kid in total and try to palpate for any mass lesions, and look if the kid is febrile, if the kid has any malaise, and look for the history of upper respiratory tract infections, like which can lead to orbital cellulitis or uh, orbital cellulitis, and look for palpate for the chest and abdomen if needed, because as said earlier, to rule out any nephroblastoma or anything like that. Proptosis, thyroid is not uncommon in thyroid disease, and orbital inflammatory disorders are not uncommon in kids, and any case that present with squinting, it's better to be evaluated properly. Torchlight examination to describe if the lesions are generalized or localized. Touch and feel the lesion. See if it's tense, if it's non-tense, if there is erythema, if there is induration. Make sure that you look for the extraocular motility in all these kind of patients. Make sure that you evert the lid and see what's in there, and look for any postural variations, and ask the patient to do a valsalvar mirror, because most of the vascular lesions can prop up with a proper valsalvar mirror or a bend down posture. And as not the least, visual acuity, color vision, and visual fields if the child is cooperative, and make sure that you see through the lids and adnexa, cornea, and the posterior findings also, because sometimes a posteriorly located lesion can present with choroidal folds, and you may have some intraocular lesions also that you can corroborate with the present findings. Imaging, as described, the preseptal lesions are mostly, if it's a cystic one, could be easily taken up by a ultrasound USG scan. Whether to take a CT or MRI in doubtful cases depends on the availability, and I do suggest to go for an MRI if the patients are affordable and the child can cooperate for the investigation, because of the high dose of radiation exposure that the kid may have to go through while going for a CT. Vascular lesions mostly will have to go for a contrast imaging, or will have to go for a DSA imaging to find the cause. And when you need to refer to a colleague, or when you need to refer to a oculoplastic surgeon, sometimes you will need to refer to a patient to a pediatrics, where we can admit the patient and give the IV antibiotics. Look if the kid is febrile, if he has malaise, if there is severe tenderness, if there is prominence of globe, if there is any limitation of eye movements or respiratory tract signs, it can be orbital cellulitis which might need IV antibiotics or parenteral antibiotics. So such cases are better to be referred on an emergent basis. And the management of lid tumors, it's a wide variety and it's a wide spectra. So some cases can be observed, some cases will respond well to medical management, and some cases will need a mild and minor surgical therapy, or some cases will need a major surgical interventions. And describe some of the rare diseases will need chemo or radiation depending upon what the cause is, or sometimes steroids also. And to conclude, history plays a major role on as to describe the course of events for the disease, and clinical examination and imaging studies help you to describe on how to deal with this, and what lesion you are dealing with also. Thank you.
Thank you, Dr.